Okay, we might get started while a few more people join us. So thank you very much and welcome to our fourth and final webinar for the GTC for 2024. I'm Amy Freeman-Sanderson and I'm delighted to be moderating the webinar series with my co-host, Professor Michael Brenner. So our topic today is environmental, financial and social sustainability in tracheostomy care, defining concepts and navigating solutions. I'd like to just take the time to thank our sponsors. So for unrestricted educational grants, so this really helps support the mission and vision of the Global Tracheostomy Collaborative of creating multidisciplinary teams of physicians, nurses, respiratory therapists, speech pathologists, many more health professionals, and most importantly, patients and their families working together to disseminate best practices, have new conversations and improve outcomes around tracheostomy care. I would like to acknowledge the countries where I am, so the place. So I'm on the traditional, I'd like to acknowledge the traditional custodians of the land. So I'm on Gadigal land and I pay my respect to the elders past, present and emerging, acknowledging them as the traditional custodians of knowledge for this land. So welcome and please feel free to pop in the chat where you're joining us from today as well. So in this webinar, over the next hour, we're going to meet these four main objectives and probably some others will come up as well. But what we're wanting to understand is what environmental, financial and social sustainability in healthcare is. To discuss the concept of the carbon footprint in healthcare delivery with consideration across the continuum of care. So looking from acute, the very acute phase in the intensive care unit, right through to community. We're going to discuss and identify activities that contribute to different sustainability outcomes. And these are going to be shared from our expert panelists in terms of their experiences across those different settings. We're also finally going to talk within the presentations and in the panel discussion about the opportunities and priorities for sustainability and tracheostomy care. So just in terms of just a brief sort of introduction, when we talk about the word sustainability, it might be a bit like through these lenses. There are different definitions that are offered, and really we're coming to discuss specific caveats of sustainability. So, you know, I guess at one level, if we're looking at the Oxford Dictionary, it offers us two different definitions. So we have that sustainability of a process, so being able to sustain over time, but we also have the avoiding depletion of natural resources. So we have these two different concepts there. In healthcare, sustainability and sustainability science is really gaining traction. And this is across both the environmental lens, but also a different area called implementation science, where we're looking at practices, we're looking at behaviours of individuals and organisations to look at what are the processes that can reduce waste and improve care and outcomes. So with that, I would like to just briefly highlight our panel, which Dr. Brenner is going to introduce further, but we're very delighted to have this esteemed panel from across the globe joining us today. So with that, I will hand over to Dr. Brenner.
Sure. Well, I'll give the in-depth introduction of our speakers in just a moment, but in broad strokes, well, first of all, it's wonderful to have Dr. Amy Freeman-Sanderson is our moderator. She's done a wonderful job collecting this slate of outstanding speakers, and she's one of the most renowned speech language pathologists, not only in GTC, but also in Australia, working in Sydney at the University of Technology and serving as an NHMRC Emerging Fellow. But we have Dr. McGrath who's a consultant at Manchester University in the NHS Foundation Trust. Dr. Forbes McGain, who comes to us, is a Associate Dean in Sustainable Health Care at University of Melbourne and has a day job working in the FCICM ICU. And then Barb also very well known to us in GTC, who is a recently retired RN with a tracheostomy, who kind of bridges the healthcare professional experience as well as that of individuals with a tracheostomy, their patients and family. So I'm delighted to have Dr. Brendan McGrath kick off our session. As you can see from the slide, he has a number of notable distinctions. He's really been at the vanguard of our efforts in the Global Tracheostomy Collaborative. But to review his history briefly, he qualified from the University of Sheffield and trained initially in general medicine in Yorkshire in the Northeast and then Australia. He returned to specialize in anesthesia and intensive care medicine, appointed as a consultant at Manchester University NHS Foundation Trust at Wishaw Hospital in 2009. He was then appointed Manchester Academic Health Sciences Centre honorary professor in 2022. Brendan's research interests are quite diverse, but all unified by an interest in airway, safety, quality, and improving overall state of care for our patients. He led the initiation of the UK National Tracheostomy Safety Project, collaborating widely in developing educational resources to guide the multidisciplinary response to airway emergencies, recognizing the real world needs for prevention of airway emergencies. He also was instrumental in developing the Global Tracheostomy Collaborative dating back to our inception in 2012, where he brought together international expertise ranging from Harvard to the UK to Melbourne with the goal of improving tracheostomy care everywhere through quality improvement initiatives. He's had a number of domestic and international quality improvement projects and research studies. He is to credit for the largest guided quality improvement effort around tracheostomy care. Coming from Manchester, the cradle of the Industrial Revolution, he and his colleagues have been instrumental also in building a more sustainable culture as well as planet. So it's delightful to have as a colleague and friend, Dr. Professor Brendan McGrath.
Thanks, Michael. That's a very generous introduction. So I've had a lot of help doing all that stuff, just to make that very clear. But I get to talk about sustainability in tracheostomy care, and particularly some work we've done recently based out of Manchester in the United Kingdom around tracheostomy education. And again, you can see from the images on the bottom of that slide, we've had a lot of help from a lot of different stakeholders in this work. So education is vitally important for all things in healthcare, but particularly tracheostomy care. And it's such a multidisciplinary specialty with multidisciplinary problems, patients who have needs that cross traditional working boundaries. And we know that education is important for staff. It's also important for parents of children who have tracheostomies. It's important for carers, and often in education for patients themselves, so that the more patients learn about their tracheostomy, the more empowered they are to seek out good care. And what we've noticed, certainly in the UK, and I'm sure we're not alone, is that there's so many people that need training in tracheostomy care because they have the potential to come into contact with patients with tracheostomies either frequently or infrequently, which pose two different challenges. So we developed a research project to try and address this capacity training. And our research question was, can delivering our tracheostomy safety course that we've been doing for years, could we do it in virtual reality? And could that deliver an equivalent learning outcome to our face-to-face course that we've been running, I think, since 2009? But we also want to understand what's the carbon footprint comparison of our virtual reality or our face-to-face training, because the VR approach is new and exciting, but we really wanted to understand, could we influence the carbon footprint of training? And then that's what I'm going to talk about over these next few slides. So you'll see, hopefully over the internet, these representations of what we were trying to do. So the virtual reality version on the left-hand side has got two people who were in different parts of the country working together in cyberspace to solve a sort of simulated tracheostomy emergency. from their perspective, it's fully immersive. You can see what's going on. You can move around the bed space. You can pick things up, and you can try and sort out the emergency, just like the guys are doing on the right-hand side in the more traditional face-to-face version. And so when we set our course up, we set them up to have exactly the same learning objectives and sort of key steps that we teach in our face-to-face course than we deployed in the virtual reality version. This is what the VR version looked like, and it was very strange for those of you who were involved in running courses or for training people. It was silent, and we're normally used to our courses being a bit chaotic with bits of plastic all over the place, and you can't find things that you need them, and there's stuff all over the floor. But it was silent, and the people who were attending the course were totally immersed in what was going on. So there was some group work and some interactive stuff where people got into their groups and were sort of connected together. And this slide shows some people in the room. There are also some people not in the room, and some people not even in the country, which is a pretty cool thing to do when you're bringing people together with this international flavour that we have in the GTC. And yeah, this was meant to represent people who weren't in the room. So just flick on, thanks, Amy. So this was the paper that we published, if you want to have a look at it, and hiding behind that headline is some of the sort of differences in the outcome. And what you'll be able to see on the chart that's hiding behind that title, get rid of it for us, Amy, please, is that when we looked at the learning objectives, we were trying to improve the candidate's knowledge by looking at a pre-course knowledge test, a post-course knowledge test, which occurred immediately after the course. And then we looked at retention as well 4 weeks later. And basically, it didn't matter which course you did, you improved your knowledge, and that knowledge gain was sustained. If you want to read the details, it's all there in the paper, but we showed essentially that the virtual reality version of our course was as good as the face-to-face one. But the interesting bit for us was to look at the carbon footprint. And again, if you want to read a bit more detail about what I'm going to say in the next couple of slides, we published this earlier this year, where we looked at what was the difference in the carbon footprint between the VR version of the course and the face-to-face version. And over the next slide or two, I'll just show you briefly the sort of things that we factored into this training. We worked with a group called the Centre for Sustainable Healthcare, and I'm not expecting you to read everything that's on that slide, but we were looking at the venues that we had to effectively build. We didn't build them, but somebody built them. We had to heat them, light them. We had to think about the power that was required to maintain all the equipment we were using. We looked at the carbon footprint of the models that we were using, but importantly, we looked at how people got there. The course was slightly skewed because we had a couple of people flew to our course, which is unusual for a local course, but we ran it as a national thing, and then people were traveling from all over the place. And compared to doing this at home, you still have to build your house, you still have to heat it and light it, but your house is used for obviously other things other than just tracheostomy education. One of the things that didn't occur when people were at home compared to the hospital was we actually send the headsets out either in the post or sometimes people collected them from work. So if you were far afield, we stuck a headset in the post, so that there were additional sort of carbon costs to the non-work face-to-face course. But I think on the next slide, we just sort of summarize what those differences were. And they were mostly around the travel and transport. So nearly half of our attendees drove to our course, about 20% got the bus, and the rest of the people got either public transport, cycled. A few people had walked, they were locals, and a couple of people had arrived by aeroplane. Most people travel about 20 miles by car with a big range. And we were able to work out that if we looked at a typical course that we run with about 20 candidates and 5 faculty with about half the people driving, that used up quite a significant amount of kilograms of carbon dioxide equivalent per course. And if we turn that number, which is often a bit meaningless when you think about, well, what's a kilogram of CO2? Well, it's about 1.5 tons of CO2 per year. The difference between running it virtually and running it face-to-face, if we ran one course per month. And just to put that into context, I think I slapped a comparison. Oh no, maybe I didn't. A comparison was if you took a flight from Manchester all the way to Los Angeles, that's about the same amount of CO2 as about 1.5 tons. So just to put that into context. So thanks, Amy. That's my bad for leaving that off the slide. So on the next slide, I just wanted to make it clear that virtual reality is not the savior. You know, it's good for some stuff. It's not great for everything, but certainly it has potential, and you can do a lot of stuff in VR with a lot of people who aren't in the same room. You still have to dig up lithium and use plastic to make the actual headsets, but once you've made them, you can use them again and again and again. And so we think there's a lot of potential, certainly thinking of the carbon footprint by delivering some of our education virtually. But it made us think about broader sustainability in training, and what VR or remote training gives you is equitable access to training. And with modern technology, you can make that training available in any language, in any location. Cost is a factor, so you've got to buy the headsets, but if you buy a headset and then 100 people use it, that's an awful lot cheaper than sending people to face-to-face courses. We know that the technology inspires, motivates people, and we know that if you invest in training our staff, you have a better trained workforce that are probably better retrained. And we know all these things when you invest in your workforce and train them, that translates through into better care. And so we think investing in education is no bad thing. And there is the reference if you want to go on and have a little look. I think that was the last thing I wanted to say. I'm going to be surprised now with another slide, aren't I? No, I'm not. The other thing we looked at was the PPE that we used. So we've ended up doing a similar sort of thing, looking at some of the plastic that we used in the pandemic in particular, but the sort of the personal protection and the equipment that we use, which I think Barb is going to touch on a little bit later on from her personal perspective. So, you know, we do use a lot of stuff in our healthcare practice, and I'm sure Forbes and Barb are going to encourage us to think very carefully about the stuff that we use. And I think on the next slide, it just gives you an example of the sort of equations that you can do when you're thinking about the plastic and on this example, the sort of PPE that we use in healthcare, to think about, you know, what are you using? Is it more efficient to use reusable devices? Is it more expensive? You can think about the economic cost, the carbon cost. I'm pretty sure that was all I'm going to say. I'm saying that now confidently. Thanks for listening.
Well, thanks for a wonderful discussion, Brendan. And one thing that I didn't mention during the introduction is that I had the pleasure of spending a little bit of time in Manchester earlier this year and to trial some of this technology. And I was truly struck by the fact that it is actually probably more engaging even than conventional face-to-face interaction. This would come as no surprise to my kids, who can't seem to separate themselves from the VR equipment, but the power of this is really quite remarkable. And I'll just ask, since you were quite brief, Brendan, and efficient, there was a question that came up about whether individuals can ask questions in real time as they're engaging with the VR platform.
So yes, it depends on the platform. The way we set ours up, it was a 3-hour course. So probably the first 45 minutes were interactive versions of recordings of me and some of my colleagues talking about tracheostomy care and why it's important, but interacting with yourself with questions that popped up you had to interact with. But then quite rapidly we got you into small groups, because one of the things that we've learned people value from face-to-face training is that interaction. And quite often we as facilitators would basically stand back and let a speech and language therapist from an ENT head and neck unit talk to a colleague from an intensive care unit, and sharing practice happens without us actually having to do any sort of education at all. And we were really keen to keep that interaction. And so you can have virtual discussion rooms. So the guys who created our course made a very nice discussion room with some oranges in a basket that you can pick up and throw around for a bit of fun. You can speak to people. People have got little name badges on. You look like a blue sort of clown waving your hands around, but you can have conversations with people all over the world. So that is good. The thing we're working on currently is to take the instructor out of it altogether. So I've got AI Brendan on my laptop, which is our next thing we want to drop into these VR simulations to see if an AI instructor is probably better than me. So that's the next step.
Thanks, Brendan. We'll eagerly anticipate the emergence of the AI new and improved Brendan. And some of you may have seen that 1824 was the founding of University of Manchester, so this marks the 200th anniversary, but perhaps even more significantly, 2024 marks the 25th anniversary of when Brendan first crossed paths with our next speaker, Forbes. And I may get this quote not quite right, but Brendan observes as he was taking stock of the meteoric rise of Professor McGain's career, is that really the non-academic bloke who I shared a few beers with as residents back in my days when I was in Melbourne back in 1999? And so I'd say both of these gentlemen have done quite well for themselves with millions of dollars in collective grant funding and happily some collegiality along the way. So Forbes McGain is director of the Footscray Hospital, ICU, and an anaesthetist and intensive care physician at Western Health Melbourne. He's also Associate Dean of Sustainable Healthcare at University of Melbourne, Faculty of Medicine, Dentistry, and Health Sciences. Forbes is a clinician researcher with broad interest in publications spanning from healthcare sustainability to ICU multi-center clinical trials and to the COVID-19 patented inventions. He has over 150 peer-reviewed medical publications and received over $1.2 million in research grants. I actually had stumbled across some of his work. He's published widely in the Lancet journals related to work and sustainability, and he remains keenly involved in teaching intensive care and anesthesia for junior doctors and students, perhaps who bring a more enlightened perspective than many of their mentors in these areas of sustainability. His research has led to environmental, economic, and social sustainability improvements in anesthesia and intensive care medicine. Healthcare environmental footprinting via life cycle assessment is a rapidly developing field for which is now internationally recognized. During COVID-19, he co-patented with Jason Monty the McMonty hood for healthcare worker protection, receiving the 2022 Australian Academy of Technical Sciences and Engineering Clooney's Ross Award. And in 2023, he received the Medal of the Order of Australia for services to medicine and the 2024 ANZC's Presidential Medicine. So it is an absolute delight to give you Professor Forbes McGain.
Thank you very much, Michael. Once again, very, very kind words indeed. And most humbling to be here. Thank you, Amy. Thanks to everyone, Wominjeka from the lands of the Wurundjeri people in Melbourne. So I really also want to mention what Brendan said, is this is all about teamwork. It is incredibly important. That's why I really enjoy ICU. ICU would not be what it is without the nurses and the allied health and everyone else assisting in the care of the patient. So few disclosures there. Thank you very much, Amy. Next, and acknowledgements of the teamwork. And look, I just wanted to move on quickly to the next slide. Thanks. So this is, for some reason, maybe this is not quite coming out as I expected, but there we go. This is a cartoon of what we're talking about for those who are novices to a life cycle assessment. Essentially, this is, let's see if you can forward, Amy, a bit the next. Does it give it doesn't. Okay, it's a shame. For some reason, it's just go back then. It's not picking up some of the other things around the slides. I'm not sure what's happening there, team. But anyway, this in fact, Coca-Cola was the first company to do a life cycle assessment back in 1969. Man landing on the moon, so this sort of international standards have developed from then about how you work out what a footprint is, whether it be carbon, petrochemical use, or pollution of air, etc. And there are about 15 standard outputs that are of interest to environmental scientists that you can use. But we tend to focus on carbon, mainly because of the climate change but also associated with that is air pollution, for example. So next slide. If we look at intensive care, this is work by Adam Pollard in Cornwall, in the United Kingdom. Did the first little look at this, what is going on in the intensive care unit. If you could scroll down, Amy, the next few little clicks. They looked at all of the things being used, and what does this mean? They said, okay, here is a person in intensive care, all the lighting, the ventilators, etc. What is the energy use? Well, it's about 15 kilowatt hours a day. Now, that is about the same as about a 2-bedroom Australian house, probably less in the US because Americans tend to use more energy because of the geography, partly. But it's sort of, okay, it's relatively big. Then the next slide, please. Just giving you an idea. And then here's a few little examples. You've got your LED light here we all know about, uses very little amount of energy. Next slide. Yep, okay. And you can see your computer monitors and even things like multiple fluid pumps, for example. It's not a large amount of energy. 100 watts per hour is pretty small. Next slide. Even things like the humidifier and the renal support, and if you can skip scrolling, you can see renal replacement therapy. It's not a large amount of energy. It's there, but once again, it's not really that impressive. So where was all this energy being used? Keep going. And so what we then went and did a few years ago was with the team from Jason Byrne and Maren Koloff from Barnes Jewish Hospital, Missouri. We looked at 20 patients with septic shock. We just followed everything that was being used to care for them. All of the equipment, all of the disposables, pathology, radiology, etc. And what do we come up with as a result? Next slide, thanks. So we've got 20 patients. What we found, and this is, I suppose, sort of the takeaway message here, was you can see the big part of the carbon footprint was actually electricity and gas. And you've got the blue for the American ICU, the orange for our Australian ICU in Melbourne. And for both of them, a big part of the story was actually heating for gas. So electricity is important, and you can imagine where you are, for the listener, thinking about where you are in the world, whether you're in a tropical area or in a much colder area like Manchester, and you'll see the differences in what is being used, whether it's heating or cooling loads. That's important. But things like plastics and rubber and laundered cotton, etc., they are important, but they're not as important. And I suppose I wanted to also show you is as we move towards a decarbonised electricity grid, like, for example, in the UK is happening very, very rapidly. You've closed your last coal mine there, then the other things actually start to become more important. So those percentages shift. It's not to say, well, let's all forget about all the plastic waste. It's more to say, work on the things that are the big carbon hotspots where you can, but that will shift with time as the electricity grid changes. Next slide. The other really interesting point is that you could just see, so imagine you're mainly perhaps the audience is Northern Hemisphere listeners. You can see the red here is space heating, so all the heating, ventilation and conditioning that's going on, and that's gas here in Melbourne, and it was in Missouri as well. Space cooling was electricity, so all the cooling of the intensive care. You've got the green for ventilation and pumps, and then you see the same, that little yellow, that was what Adam Pollard's group looked at. So that was the ventilators and the ECMO and anything else that you might be using as machines to care for patients with septic shock. So it's actually rather unimportant. So even though it looks whiz-bang and you'd think it uses a lot of energy, it's actually what we feel that matters, not so much what we see. The other interesting point is, I found it quite fascinating. This is the advantage of doing life cycle assessment, is it throws up surprises all the time. You can see January in the Northern Hemisphere is, of course, your cold month, but for us, sorry, just go back, Amy, just very briefly. And in Australia, you can see red, which is actually heating at night in summer, is still using more energy than cooling at night or during the day in summer. So it's really interesting seeing these effects of where we've got to move on and what's important. So the other important point is you can see that number of 30 houses there. So in other words, we had a relatively small ICU, 12 beds. One patient, caring for one patient is equivalent to burning 2.5 houses worth of electricity and energy and that sort of stuff. So it's actually quite a lot of energy being used per patient. Next slide. I think the big takeaway message for the team here is that just keep rolling there, Amy, thanks, is that getting off gas is really important, because even if we do transition to renewable electricity, and that's already happening in large parts of the US and UK and Europe, for example, but that will not change the problem with gas for heating. Next slide. And I just wanted to show you here to perhaps embarrass those who are not as far north as the Orkney Islands of Scotland. This is the first all-electric hospital in the UK. I'm looking forward to Manchester. Sorry, there's a lot of ripping going on here. Being the next hospital that will be 100% electric, no gas. It's going to be, I'm looking forward to that before the end of the next millennium. So I think that's really important to think about, okay, how we can be advocates for that, because one of the things we've been engaged with, the senior medical staff at my hospital and beyond, doctors for the environment, we've worked on now, we're starting to build all electric hospitals in Australia. And so it's really exciting because that gets rid of the whole gas story completely and changes the whole story. Next, please. I think just as a little aside, little interjection there, sustainability in the ICU, we're working with the Intensive Care Society now beyond ANZCS, the Australian New Zealand Society, to develop quality improvement, I suppose, processes that can be used by all nurses, doctors, etc., in the intensive care to be more sustainable. Nice resources. Look it up if you haven't seen it before. Next. So here is our ICU. Here is we went through 1 million PPE gowns at just one hospital alone in 2020. 1 million. We then converted from disposable to reusable, and you can see this is a reusable gown. So for PPE, as a result of the COVID pandemic, we transitioned. It doesn't save much money, but at least it's cost neutral. And in fact, over in the far right-hand corner, you can see someone dressed in blue gown. That's a person putting in a central line. Yes, I should be watching them. And this is the process of saying we've got not just PPE non-sterile gowns that are reusable, we also have the reusable sterile gowns for central line insertion, for example. So I think just showing you that you can transition, it's possible to do so. Next slide. And then reading away, completely unbeknownst to me, this is a good example of where nursing staff are charging along. They said, well, you can do that for gowns. Let's go and do that for pads and other things for patient care. And so here's some examples of reusable pads and other equipment used for standard patient care, standard linens. It's not rocket science. It's not whiz-bang new technology. It's actually old technology, but it's actually been improved. The good thing about this sort of stuff is it has been improved. So, for example, we're doing a little project now with the infection prevention and wound care nurses actually looking at comparing reusable pads versus disposable ones. And you can actually make reusable ones that are better than disposable ones. So that's actually quite exciting for patient care as well. Next slide. Just to finish up soon, just a few different things that will be relevant to everyone in the group. There are studies now, we've got pathology testing. So all the FBEs and electrolytes and all the other tests you do on a daily basis, and you see there are footprints now of that. Next slide. This is showing you that the full blood examination, for example, your white cell count, etc. One of those little tests would be like driving a standard car 3/4 of a kilometre. So it's not very much at all, but it's just the sheer number of these things being done. And as opposed to my story, I was talking about reusable versus disposable. This is much more of a story about just reducing unnecessary, choosing wisely, for example, because you can't really be recycling these blood-stained tubes, but you certainly can reduce the number of unnecessary ones. So that's the other area that we want to work on. Thanks. Next slide. This little one here showing MRIs and CT scans, so looking at radiology now. This Scott McAllister led, he's our life cycle expert that I've been working with for 15 years. What it's showing you, I suppose, is looking at that big bar of the MRI, just focus on the big bar. You can see A at the bottom. That's showing you that one MRI scan is similar to burning about 8-9 litres of petrol or 2.5 gallons of oil. So think about what your car might be able to do with that. And if you've got an electric car, well, you can double or triple it in terms of how you might be able to drive. Next slide. The other area was looking at paracetamol or acetaminophen for some of the viewers. This was a US, UK and Australian study. Just move along to the next slide. I just wanted to show you, because I showed you pathology, radiology, and now a bit of pharmaceuticals. The important takeaway point I want to show you from this graph was that you can see the light blue active pharmaceutical ingredient, API and formulation. So you can see that that is the main part of the story, obviously, for your tablet of acetaminophen, paracetamol, but it's a very small part of the story for the IV glass vial or plastic vial. So in just that story, we all intuitively know it, that if you use an intravenous preparation, it's going to have a much higher footprint than an oral preparation. But the point here is that you can, in intensive care, I've always found it rather strange that we use so much IV paracetamol in some areas and not in others, and that's the same in anaesthesia, when we could actually be using oral paracetamol. Saves money. It's about 1/100th of the cost per tablet versus an IV preparation, and it is about 1/50th of the carbon footprint. Next slide. So finishing up there, just some thoughts, all sorts of different things you could be doing on a day-to-day basis on your ward round in intensive care. And next, just roll down. But in addition to that, I put it in red there deliberately because I know Barb will be able to speak eloquently of such things, is the role of the ICU patient in becoming more sustainable. I think the tricky one, there is some degree of tension there because we want to provide excellent care for the patient. But I think I actually sometimes, wonder how many ICU patients have they found out just as a post-survey that, so much of their blood was taken unnecessarily for clotting profile, for example. I think they'd be horrified to discover how unnecessary many of the things we do are. Thank you very much for your time, and looking forward to discussion. Cheers.
Thanks so much, Forbes, for a wonderful talk. Really an eye-opener and very illuminating for many of us. I'm sure there will be lots of questions in the discussion. I'll just offer one at this point that came to me as I was looking at that discussion. So there's been some interest in, you gave the example of laundering, and there's been some interest in cold versus heated laundering, which perhaps has even more implications than heating of air. Is that something that is feasible or with MRI machines, presumably we've been seeing higher and higher Tesla MRIs from 1 to 3 to even, I think they have 7 or higher Tesla MRIs that probably are more energy consumptive too. And conversely, we see scans that are sometimes more limited. Are all these opportunities just waiting for us poised to be taken, or are there major obstacles to implementing some of these changes?
Both. They're all poised, but there are major obstacles. So I think that this is another. A lot of what I've showed you, the team there, is about the what. What is the carbon footprint? And we've moved a little bit into the how to change things. And I think that implementation scientists are going to be incredibly important in making that change, working with us in this area. That's one of the areas I've been engaged with one of the PhD students and anaesthetist Jess Davies. So at the University of Melbourne. But I think that probably I would say it is a carte blanche. There's an enormous. It's a blank slate. There's an enormous amount of opportunity here, Michael, to make changes that are sensible and realistic. I think taking what we've learned from choosing wisely is one way to do it. But it does require ongoing engagement. It's not something we can just walk away from because these things otherwise will slip back to what they were beforehand. And so the example, just for example, you mentioned the reusable gowns, for example, or washing cold versus hot. A fascinating discussion. We've sort of talked about that before, but that's a little bit out of my remit or control because that's much more off-site, what the laundry services does, what the requirements are there with infection prevention, etc. So I think they're all conversations worth having, questions worth asking. I don't have the answers to all those questions, but I think that each one of them, whether it's an MRI scan or different types of laundry, they're all worth discussing. I think for the listener, I'd focus on one thing that you can feasibly do and get on with it. Yeah.
Wonderful. Well, thank you so much for both this talk as well as your contributions to the scholarship in this area. It certainly made me think, as we've seen some of these shortages in the US and maybe internationally of IV fluids, now we often have patients orally hydrate. That works just fine. And when you look at, the difference that you showed of a vial injected of what we would call acetaminophen or paracetamol. It really is staggering. So lots of opportunity. So as is often the case, we have left our best for last. We now have Barb Bosworth. So by way of introduction, she's been known to the GTC and a critical contributor for quite some time. She's a retired RN with a tracheostomy. She became a nurse in 1975 and received her trach in 2022 for severe obstructive sleep apnea when CPAP would not keep her airway open. She worked several years with a trach, but had a hood stoma stent, so it was easily hidden underneath a mock turtleneck. 8 years ago, she switched to a regular trach tube after an episode where she had respiratory arrest after granulation tissue completely blocked her airway. She's the moderator of the Facebook Tracheostomy Warriors page. This is a social platform started by our president-elect and current vice president, Dr. Vincia Pandian. And that site serves to support people with a tracheostomy and their families. Barb has been really a thought leader and incredibly proactive in spreading word, across literally dozens of different sites that engage with tracheostomy care. And it's just been truly wonderful to have someone poised at the intersection of patient care and the experiences of having a tracheostomy yourself. It's my true pleasure to give you Barb Bosworth.
Good morning, or is that your name?
Oh, I'm sorry, Barb?
So I guess I'm not on the screen, but that's okay. So I'll go ahead and start. So having a nursing background it's taught me, what I can and cannot do. So for many years, I did a lot of sterile procedures. And then there's also clean technique. And in the real world, when you get home, clean technique is basically what we're going to be using. The most important thing of functioning at home and clean technique is good hand washing with soap and water. In hospitals, I worked for 10 years without exam gloves. There weren't any exam gloves until the AIDS epidemic in the mid 80s. So you washed your hands a lot. And if you wanted to use a pair of gloves, the only option was a size sterile surgeon's gloves, and you had to have a good excuse to open them. So yeah, lots of good hand washing. So even though there's lots of policies and procedures in hospitals, on what to do at home, you're going to have to make some improvising. It's just the way that the world is. Some of us are fortunate. We've got great insurance and we've got great DMEs that give us supplies. But there's a lot of people out there that are completely on their own. And it's like, well, what do I do now? What can I use? So as far as sustainability in home care, there's a lot of waste. And so you try to figure out, what I can use and what I don't really need. So as far as trach tubes, of course, the most sustainable is going to be the metal trach tube. And in the US, there are some people who have the metal trach tubes like the Jackson, but they seem to be more popular in Europe, in the UK. So in the meantime, we basically have plastic tubes. And even though the manufacturers and the FDA in the US says they should be changed every 29 days, in reality, the insurance companies say, well, it's going to be 90 days. So for me, I find that around week 9 or 10, I start getting annoying mucus plugs. And maybe once a year, I can make it all the way to 12 weeks. But in reality, it's not happening. So I have a Shiley XLT proximal. And with that tube, I tried to clean and reuse. But I found that and I'm pretty gentle with them. I use hydrogen peroxide because that does melt mucus. And I use pipe cleaners because with the length of my particular tube, the standard trach brushes won't reach. So trying to clean and reuse, for me, instead of getting 10 weeks, I got 1 week before those annoying mucus plugs. So for me, cleaning and reusing my particular tube is not working. So, but I know for others, there's a lot of people out there that do clean and reuse. A lot of facilities have policies and procedures, like with peds, you can clean and reuse them up to 5 times. With adults, it's up to 10 times. But it may depend on the particular brand that you have, whether or not you can, what works for you may not work for somebody else. So, you know, having a trach does require a lot of supplies. And again, you know, we're usually getting a new trach tube every 3 months. The inner cannulas, most insurance companies, again, kind of tell us what to do. Some allow us up to 2 inner cannulas a day. Some people need more than that. So again, they have to clean and reuse. What I do is I go to Michael's in the kids section and get 12-inch pipe cleaners and take 3 of them and fold them over and just kind of remount the inner cannulas. So, but you know, for others, that's not going to work for them. So again, you kind of make do, and if you have to clean and reuse or soak them and clean them, you do what you're going to have to do. So the trach brushes, again, won't work for my particular tube because it's extra long, but for others there are the trach brushes. So there are trach cleaning kits available, and I find that I'm probably not going to use most things that are in there. Again, the sterile gloves, I'm not wearing gloves. I'm cleaning myself. You know, I'm working with my germs. I'm not in a hospital where there's lots of bad germs, and wearing gloves is most important. But at home, good hand washing. Some of the other things in the kits, you know, the Q-tips, sterile Q-tips and pipe cleaners or trach brushes, the sterile gauze. You can buy packages of, like, you know, 200 non-sterile but clean gauze pads for a couple bucks. So, you know, these trach kits take up space. You know, shipping is more expensive because they're bulky and the combined weight. So for me, I don't use them, but they are available for some people. The same thing too with sterile water, like for your humidifier. Distilled water works great. I've been using distilled water for years. You know, basically, that's what's going to work at home. In the hospital, yes, they have to use sterile water containers. So the other thing too, as far as, you know, special trach dressings, there's the Mepiplex. There's the gauze pads that have a slit in them. And those, you know, it's extra waste. Mepiplex is expensive. It's about $5 each. I use a paint sponge under my faceplate, and it's a paint sponge that I punch a hole in it with a leather hole punch, and I can reuse these several times. So I rotate about 3 of these, and they last me about 6 months. They cost about $3 each, and they also, for me, because they're a sponge type, you know how you leak in a little bit of air around your stoma because the tube isn't quite as big as your stoma. It helps seal that up so I'm not real breathy when I speak. So for some people, it may be too thick. But there's also like pads in the cosmetic aisle that you may be able to clean and reuse. And they're a little bit, you know, less visible than a white gauze pad. So I've been using these for years. So yeah, you can improvise. You know, just kind of use some common sense, try to keep things as clean as possible. As far as things like suction catheters, I don't need a suction. But I know that one of our members is a doctor who has a trach, and he recommends soaking your suction catheters in Listerine because it has the highest alcohol content of any of the mouthwashes. So, it's about 54 proof or about 27% alcohol. So yeah, it's stuff you can get at the grocery store, and it works. So yeah, so it's as far as sustainability, you kind of have to use some common sense, clean and reuse stuff that you can, improvise, but try to keep things safe, and just get on with it. So you can get by with things that may not be available to everybody. Thank you.
Well, thanks, Barb. We really appreciate your sharing those insights. And what was so beautiful is that it was such a wonderful segue from what Forbes had highlighted about how you don't have to try to save the world. You can just start with some small thing that you can do in your own space, and you're walking that walk, with a lot of practical tips that you do day in and day out. It was striking to see that slide that you showed, Forbes, from I think it was actually from 2019 that they completed, well, a slide maybe from a few years later, but that they completed that hospital. So just showing that on both small and large scale, it's possible. So I think I'll go ahead and hand things over to Amy so that she can moderate the session from here and field some of the terrific questions from the audience or some of her own.
Thanks, Michael. Thank you, everyone, for really enlightening presentations. And I suppose there are lots of questions that have come up, and sometimes that's great because the more questions we have, it shows sort of a gap or a need to explore the pathway forward. So across all of your presentations, there were some themes that came through. So themes of the provision of care, quality care, managing it with safety, and looking at sustainability. So where do we start this journey? So we've got individuals on the call that are patients and families, healthcare providers. So what's a way for us to engage as individuals? What would be a place to start conversations? So I'm starting with the big questions. Who would like to take that first, Forbes? I can see you.
Well, yeah, so I think as Barb has eloquently stated, and so as Michael, it's a journey, and it's not as if I came to all of these things within, like the first few days of working in intensive care. And I think, and I'm just trying to think of how it would be relevant to this group of tracheostomy, as opposed to, I suppose, the whole concept of intensive care more broadly. But things that would expedite patient care always it must be beneficial to a sustainability point of view in the vast majority of the time, because getting someone out of intensive care earlier is something the actual patient wants. They don't want to be stuck there in a bed. So those sorts of processes of decomplexifying, simplifying, getting the arterial line out, whatever it happens to be, reducing the amount of unnecessary blood tests, are just vital. So what I'm trying to say to the group is that whatever you're doing on a day-to-day basis as a clinician should always be designed to efficiency and improvement in patient care. So I wanted to give that lens first before I started, say, talking about, I don't know, carbon footprinting of reusable versus disposable laundry equipment, or laryngoscope blades, or those sorts of things, which are good, but they're probably the next level. And stories about getting off gas, they're meso to macro level things. They're not really the micro level things that everyone can do. So hopefully that begins. I think that's how I'd be focusing on what you can do every day.
Yeah. I'll just ask you, Barb, from looking at home care, looking at patients and family, what would be a way in terms of starting conversations and supporting these conversations? You mentioned a lot of the these parts that you've had to figure out alone. You've there's individual needs and there's some shared needs. So what would you like to see moving forward in terms of having these conversations and shifting the pathway to sustainability?
So, there seems to be a drought of training, and as you guys have talked about, for patients, they're just released without training at all. And so some of these Facebook trach groups have really filled that void. And it's amazing some of the problems that people have and some of the solutions that the members on these Facebook groups can offer. So this has been a great tool for kind of getting the word out and problem solving, things like that.
So, and the importance of those different channels for communication and how we sort of use those to sort of have a shared understanding. And I mean, you brought up training, and that segues nicely into what you highlighted, Brendan, in your work in regards to the training. So do you sort of that rollout of training? So I see in the chat AI McGrath, but also yourself. How do we also push that forward with patients and families as well as clinicians? Do you see a space there in terms of furthering the work you've done already?
Absolutely. It works both ways. And one of the things I was going to just say, it's very much a team game. And I think every time we have these meetings, interactions, and almost every time you meet a patient who's been living with a tracheostomy, the patients and their family usually know an awful lot more about tracheostomies than I do. And, simple things that Barb highlighted, the fact you can do a lot of your care yourself and you don't need to sort of open all these sterile things we do in a hospital just to clean an inner tube. I guess someone who's sick on an ICU, it is a slightly different scenario than someone who's perfectly well at home. But these sort of webinars are an opportunity for us just to sort of stop and think about what we do, and with some of those facts and figures that Forbes provided for us, it is quite striking that some of the things we can do really do make a really big difference to sustainability and that sort of carbon footprint. But I think as Barb's highlighted, it's a challenge to all of us that educating patients about what they not can and can't do, but what you can, the standards in hospital don't necessarily apply to the community. And if it works for you, then that's okay. And there's plenty of people like Barb and her colleagues on a Facebook group who thrive outside a hospital, not doing the sort of things that we think we need to do in hospital. So I'd say it's a two-way thing. I think patients have got a lot that we can learn from, and equally, it's probably landing on the doorstep of people like us and groups like the GTC to have a role in disseminating that information. And if we all do our bit, that's what helps to sort of oil the wheels and take us along that road.
Yeah. And I'll just final two questions before I'll close the webinar. But we've got a question from Paul Twose about even though we've got evidence that VR is non-inferior, so how do we shift the culture and expand the use of immersive technologies for staff and environmental benefit?
That's a good question, and Paul knows a lot about virtual reality. I think he was the guy who got me into it, and I was struck when Paul showed me some of the things you could do in VR about how you could scale it up. And we spend a lot of time training, or a lot of time trying to train, and it's a huge burden on the trainers. I think virtual reality can liberate a lot of that time and leave the trainers to do that sort of high impact bedside interaction that really adds value, rather than going through the basics with lots of different people. I think we need some use cases. So one of the things we're thinking about is parents with children with new tracheostomies. We have an idea that using things like VR, we can give people headsets to take home. We can get the school teachers, the carers in the community. We can get them pretty rapidly trained to a pretty decent level. You know, it's not, the VR's not solving all of the problems, as I alluded to, but you can do 90% of the education that we do face to face, and so you can quite rapidly upskill carers, healthcare professionals, parents, patients, families with this sort of technology. It doesn't have to be a headset. You know, just thinking about the way we deliver education can really help to sort of make these changes. But to answer Paul's question, I think it's about challenging, you know, what we do, because we've always done it, showing that it can save time, produce better care, save money. It's sustainable. It maybe is of benefit in retaining our workforce. They're the sort of things that that will get it used, and certainly in my healthcare system, showing it saves a bit of money, whether that's getting people out faster, whether it's making training easier to access, and all the other things that we sort of discussed. So use cases.
Yeah, thank you for that. So just last thing, in terms of, all of you really spoke about the differences across considering individual settings and needs, and highlighting there's not one solution that goes across all those needs or across all those settings. And it's not sort of a giant leap from one to the other. There are steps in between. And to sort of segue, and I guess to sort of summarize it, you all sort of talked about micro changes, almost like atomic habits, right? So changing one small thing a day. So in terms of, you know, one small thing to change, what's your one leading point about one thing for us to change and consider moving forward? So I'll start with Barb. So one question that we should ask ourselves.
How to get by day to day with what's available.
Okay, thank you. Brendan.
I guess I've focused really on education, and so thinking about how we ensure that we've got a minimally accepted standard of training, and all those people who are going to need to know how to look after tracheostomies. And that's a difficult question depending on where you work. There's lots of complexities in our healthcare systems, but delivering a standard of training en masse is my current challenge, and that's the sort of thing that we're working towards.
Okay. And Forbes.
I think that a bit of a combination of what both Brendan and Barb were saying there is, but that education, it does strike me, picking up on the chat thread, that, you know, people saying there's a lack of education of people with, you know, with tracheostomies as they're leaving the ICU. They don't really know what to do. It hasn't been helped as much as perhaps could be expected. So obviously there's a huge need, and Brendan seems to be moving into that field of using virtual reality and other modes that simply we just do not have enough people. Or even if we do have enough people, even if Brendan's there talking and the nurses are assisting and the physiotherapist or whoever it is, but there's still the follow-up that's required. All of us need that follow-up, and also that reminders, oh, did you consider the cleaning or whatever it is? And I think that's where new technology of whatever sort will be incredibly important. So I think you're thinking about that, because preventing one unnecessary admission to intensive care for a tracheostomy that's gone horribly wrong is, of course, massively important for that individual patient, but it's also incredibly expensive, incredibly environmentally unsustainable. But, you know, it's all of those three. Thanks.
Thank you. I would like to thank our panelists for their time, not only today, but also in the preparation and all of the work prior. And thank you to our audience as well, listening live or on the recording. So we are rapidly coming to the end of 2024. So this is our next webinar for 2025, will be on February 6th. So please look at the website to stay tuned for the topic. So with that, thank you again, everyone. And I hope the end of the year is a good one and the start of next year is a healthy one. So thanks for your contributions.